Okay, we're live. So, welcome everyone to today's program. My name is Hamza Malik. I'm a general dentist working in Dublin. I work mainly in Malahide and then in city centre as well. And it's a real privilege and honor for me to be here today speaking to you guys a bit about posterior quadrant dentistry. So, when I was initially kind of asked to do this presentation, I thought long and hard about different topics I could present, and I stumbled upon this area because I'm a general dentist, and for me, it's a large portion of the work I do. So for a lot of us, a lot of the people attending this are also general dentists, and this is everyday dentistry. It's what pays a lot of our bills. It fills a large proportion of our diaries. Another reason is quite a large volume of patients actually need this kind of treatment. So there's a high need of it, and there's a lot of demand for it. And I believe it can be enjoyable. A lot of my buddies, my colleagues, they complain saying they don't like doing a composite or a single crown anymore. They're more interested in kind of the big aesthetic cases or other areas of dentistry. And I really enjoy those areas too, and I do a lot of them. But this is kind of the bread and butter, and I think it can be really enjoyable. And I think the kind of the key in this is that you take the time to do it properly. So you're not going to enjoy this kind of dentistry if you're booking 20, 30 minutes for a restoration. In order to do things well, you need the time. And obviously, that may mean that you may need to charge more for the treatment because you're taking more time. So there are a lot of benefits to doing multiple teeth together instead of doing single tooth at a time. Um, whether we believe it or not, our patients don't actually want to be in the chair. So one appointment to do multiple teeth means that it's one LA, one rubber dam, one visit, one day off work. It's also a lot better for our production. So you'll be grossing much more if you do multiple teeth in an hour. And the reason being is because you gain a lot of time because you only have to do things once, LA once, dam once, matrixing once, bonding once, and then adjusting occlusion and all that all at once. It's also more time efficient. So if you find yourself like me, being 10, 15 minutes behind constantly, uh, it's a lot easier to catch up in a longer appointment than it is in a shorter one. So if an appointment is half an hour and you lose 10, 15 minutes because you're late, um, you lose effectively 40 to 50% of the appointment time. And it becomes a nightmare trying to catch up, and that passes along your day, and it can be really stressful. Whereas if you have a 2 hour appointment, the beauty of that is that even if you start 15 minutes late, you still have an hour, 40 minutes, and you can finish on time. I find myself being able to catch up a lot easier if the appointment is longer. And the final thing is, if you're a dentist doing, single tooth dentistry right now, and you have aspirations and you would like to do more complex dentistry in the future, it's a great stepping stone to learn how to do that. So maybe you can go from one tooth to three to four teeth in a quadrant, and then eventually work your way up to doing a full arch of treatment, or with the end goal of doing the full mouth. And really, the difference between a single tooth and multiple teeth is occlusion. And this will really teach you a lot about occlusion if you're doing quadrants, like three, four teeth together. Things like guidance, things like static contacts, how to use articulating paper, and we'll talk about some of that today. So before we get into it, camera, as I've been taking pictures since I was a student, and a lot of people will want to, will ask what I'm using for the photography. And, I've had a few cameras over the years. A lot of the pictures in this PowerPoint are taken with my most recent camera, which is the R8 100 millimeter macro lens, and then a Sigma twin flash, which is like sorry, it's not Sigma, it's Yang now, which is like a Chinese brand. But I find it really nice. It's just that the battery is not probably as good as the Canon one, but it's about maybe a fifth of the price. And initially, when I started, I had a much cheaper setup, which was like the 2000D. That whole setup is probably available for less than 500 if you get it on the secondhand market. The RP is something I had for a long time, maybe 2 or 3 years. I had that camera, and it costs maybe the whole setup is about 2 grand, whereas the R8 setup is probably around 5K. So, there's an option there for each budget. If you're just getting started and just want to take photos to kind of show patients their problems or communicate better, you can start off cheap and then eventually upgrade to something nicer when you've kind of improved or taken photos as well. Right, so some core concepts we all probably understand pretty well, but it's important in our decision-making process. So we'll briefly cover these. Caries, so everyone knows what caries is. Fusayama is a kind of a pioneer in adhesive dentistry. He's kind of considered the father of modern day adhesive dentistry. He's a Japanese dentist, and he described caries as being outer and inner caries. Now, outer caries he described as being infected, and inner caries as affected. That's all good and well, but what does that actually mean from a clinical point of view? And a lot of dentists say, "Oh, you feel how soft the dentine is, and you remove it based off that." But that's very subjective, and there's a need for something a lot more objective. So there's a consistency between the same practitioner even and other dentists as well. And this is really where the peripheral seal concept, which was described by Manier, who's a very famous kind of adhesive dentist, and he's well known in the adhesion world. And basically, what he described is that we need to remove all the infected outer caries, and with the inner caries, we can decide to leave it and be more selective. And the idea is that if we have a well bonded restoration, our caries can't progress because the bacteria is separated from the substrate. And that makes a lot of sense because we know we need time, we need an acidic environment, we need fermentable carbs, and we need bacteria for caries to progress. And if some of those links are missing, it can't progress. In terms of diagnosis, a lot of us will be using a good clinical examination on dry teeth, using radiographs, and there's a lot of other systems out there, like Diagnodent or laser fluorescence. And nowadays with AI, there's a software called Pearl, which I've seen in action a few times, and I believe there is use in it. I haven't adopted it entirely, but it's something definitely which is exciting. So I kind of pointed out there's a need for an objective caries removal tool, and caries dye is the answer to that question. So all we're doing is we're applying caries dye on a micro brush, scrubbing it into our cavity, rinsing it off, and then we need to remove decay respecting our endpoints. So if I go back to this here, you can see um, 5 millimeters from the occlusal surface and 3 from the proximal is kind of our limit as we're approaching the pulp at that stage in most teeth. Now you will use your radiograph as a reference as well, but it's a good kind of a idea to have in your head. And then we're leaving the inner caries. You can see this tooth has no endodontic problems, vital, responds normally, no pain. And you remove the outer caries and the inner caries, which is affected over the pulp at our endpoint, we're not removing. So people tend to understand caries really well generally, but something that's a lot more less understood or misunderstood is structural analysis and deciding what to do with cracks. So Kishan described how to crack a cusp. How does a cusp break down? And the kind of the features he listed were that there's a crack in the peripheral rim. So in that big amalgam, big juicy amalgam right there, for ready for indirect, you can see the little fracture line on the distal marginal ridge, and that's called a peripheral rim fracture. That's basically the two showing signs of fatigue. Isthmus width greater than 2 millimeters, so that amalgam is quite wide, so you can see it's greater than 2 millimeters, which means that the thickness of the cusp is less as a result. Then again, we're measuring the base of the cusp width, and we can use that with like a calipers and minimum kind of thicknesses which are accepted with 3 millimeters for flexural cusps and 2 millimeters for tension cusps. And then finally, a box greater than 4 millimeters. So that mesial box is way more than 4 millimeters, like six, probably six, seven. And all these are features we're looking for when we're deciding on whether we're keeping a cusp or are we reducing the height of the cusp. Another thing is a cuspal deflection. A dentist called Ree discovered that if you do a class 1 cavity in a tooth, there's a 20% reduction in the stiffness of the tooth. which is quite a large sum. But even more surprising is when you go to a class two, there's a 46% reduction, and that's one box, either a mesial or a distal box. And with an MOD, it's more like 65%. So really it shows that there's an importance of the marginal ridge in the structural integrity of the tooth, and therefore we should always kind of aim to preserve that if possible. So indirect versus direct. So direct composite has a big problem of polymerization shrinkage when you're curing it. And research by Yamamoto and Hollenbach described that if you go indirect with a cement thickness less than 200 microns, you generate less contraction stress than like your direct composite. And honestly, it's a lot easier to do as well. And there's other advantages to going indirect, like occlusal control. So if you reduce the buccal platal cusp of a tooth, and with a dam on, it's hard to gauge how much to build the tooth to get a good occlusal contact. Periodontal health, so using matrix bands, it's a lot more difficult than cementing an indirect restoration. Better contacts, proximal contacts are made in the lab, um, on models or printed models, and occlusal contacts as well are determined in the lab. So in the lab, the models, you can move them around wherever you want, and it's easy to check contacts. And then ceramic has better physical properties than composite. So a professor by the name of Sorensen, who was kind of a UCLA professor in prosthodontics, and he was a prosthodontist himself, was jokingly referred to by a famous person in adhesion, Ray Bertolotti, as the first prosthobontist. So the reason being is because he was a really early adopter of adhesion back in the 80s when it wasn't that common. It was more retention, resistance form, kind of conventional dentistry. And he really focused on enamel preservation. And today, we understand that enamel is really important for the integrity of the tooth. But at the time, this was kind of pioneering. And the reasons he described for keeping enamel was a superior bond, so more stable bonds over a long period of time, lower sensitivity. Enamel's a dead tissue, dentine's a living tissue, so lower sensitivity as a result of that. A lower endodontic treatment because of their superior seal and better bonds, and an improved support of the ceramic restoration. So ceramic has closer physical properties to enamel than to dentine. Dentine's a lot more elastic, a lot more, the modulus elasticity, it expands and contracts a lot more. And if there's a stiff ceramic restoration sitting on top of the dentine, and there's all this movement and expansion and contraction underneath, it increases the chance of problems like chipping, crack propagation, breaking of the ceramic. Whereas enamel mimics ceramic a lot more, and it's stiffer and harder material, and it doesn't expand and contract as much. So the ceramic is well supported because they're more similar in properties. So using all that, what does that mean clinically? How do we make a decision? So before we kind of decide to do something with the tooth, as part of our examination appointment, we're looking at, there might be caries, there might be a crack, there may be a fractured cusp. We're just looking at the tooth and trying to get a good educated guess or an estimate of what we will probably be doing. Now, you can't say for certain until you remove the restoration, but when I look at this upper sixth, you can see the distal cusp is going to get reduced regardless of what's underneath because of how thin the cusp is. Whereas the other three, might have a chance, and we'll make that final decision, final call uh, when we're actually doing the procedure. So at the exam appointment, I would say to the patient, cusp missing, ideally would be indirect. And then if for some reason they can't do indirect, we have to go with a direct. But at least you can tell the patient what procedure they need rather than saying it could be a filling, it could be an onlay, it could be a crown. Um, you're more certain as to what you're doing. So for me, if it's a cusp missing, I'm offering indirect and then doing composite if they won't accept it, or if finance is an issue, or composite with a long-term goal of converting it to an indirect. And in this case, our kind of estimate or prediction stands true. We got rid of the distal platal cusp and kept the other three cusps. And this is after air abrasion and sealing the dentine using SE bond and Genial Universal, and there's a little bit of Everex posterior there as well. So on to some practical advice. What are some things or materials I found to be really useful? For me, my probably my favorite burr of all time is the long shank round burr. The reason I love this burr is because the shank is really, really long, as it says on the box, and it allows you to get to the seven or the six from the handpiece being in the five or the four position, and that's really nice for access. A lot of times, dentistry it's like an angles game. It's access is an issue, and this burr overcomes a lot of those challenges. Another reason is because it's round, it's a sphere, it's spherical in shape. It doesn't matter what angle you cut at, regardless of where you're tilting the burr. A circle is always a circle, so low skill required, for to use that burr. Whereas some of the other burrs, like chamfer shoulder, by angling it a certain way, you can really over taper, you can really knock into the adjacent tooth and stuff like that. But this burr I love for those reasons. And I have it in a variety of sizes, so very small for like breaking contacts. And the way I would do that is drop the burr, keep a very thin wall of tooth between the teeth, and drop the burr and just go buccolingually until I broken the contact gingerly, and then use a flame burr to kind of break off the mesial portion, the distal portion, and come out through the embrasure. And that allows you to do a class 2 restoration really quickly. And hitting the adjacent tooth is, people use separators and metal matrices to protect the adjacent tooth, but I've never had that problem because I always keep a thin wall of tooth, which acts like a separator. So that's kind of why I love that burr. The big one is great for removing cores, removing amalgams, removing it, clearing DJs. Another great one is the burr, which is the end cutting only burr, and that only cuts at the tip. And it doesn't have a cutting at all on the sides. And I really like this burr for again dropping boxes because you can't hit the adjacent tooth. There's no diamonds on the side, and then especially for when you're finishing a restoration before you scan and you've sealed your dentine and you have adhesive and maybe some material on the margin, you can just turn the speed down and go around the margin with this burr and expose the enamel again without touching the dentine which you just sealed, which kind of defeats the purpose of sealing the dentine if you're cutting into it again. And then really the big game changer, electric handpiece. I would say I have a very average pair of hands, but I have a really, really good plan. And that's what I think is the difference. And an electric handpiece allows you to, turn the speed down, have amazing control over your preparation. And the other thing is it's not stopping like a turbine. When you press too hard, the turbine just kind of stops and goes, stops and goes. This is very consistent, continuous torque. It's powered by an electric motor, so a lot of the challenges of turbines you don't find. The only thing, kind of the downside of it, I think it's a bit chunky. Like it feels a lot nicer to hold a turbine than it does to me to hold an electric handpiece. But definitely something if you want to do nice preps and take them to the next level, it's something you have to have. Okay, so rubber dam, another essential part of the armamentarium of adhesive dentistry. Really, we're relying on adhesion and moisture control is imperative. You can't bond onlays in a bath of saliva and expect it to work. You'll have problems like debond, sensitivity, um, all stuff we don't want. So rubber dam, the gold standard for isolation, something you have to use because we're not relying on retention resistance a lot of the time. It's more so adhesion. In this case, it's an isodam, which is a non-latex rubber dam. Medium is kind of the thickness. And the reason I love this dam, is it's really easy to get between the contacts. Uh, and blue, it's blue. I really like the color. Blue is a lot nicer than the other one, which I'm going to show you, which is green. And in this case, I'm cemented onlays on the 7 and the 6. And you can see there's a clamp on the 7, which is the anchor clamp holding the dam down. But then I have an accessory clamp on the 4, which is a 2A, a premolar clamp. It's winged. And the reason for that clamp is to prevent the matrix from the rubber dam from lifting mesially. Sometimes you can find the rubber dam jumping up, and the other reason is to prevent the lingual rubber dam from folding over onto the preps. And that's a very stable setup. You can even put cotton rolls underneath the, let's say, the buckle arm of the seven and the four, and it keeps the dam down even more. Uh, but that's just something I found really useful. In this case, it's a Nictone, which is a latex rubber dam. Really, isodam is what you should go for. We should all be latex free. Um, don't want any extra stress with allergies and that sort of a thing. I never had an issue, but you never know. And in this case, it's a seven is a crown, six is a non-lay, five and four are direct composites. And the nice thing about heavy rubber dams is great for deep margins. If you have a deep margin on your prep and you're trying to cement non-lay, the medium dam is a lot harder to invert. The heavy dam will invert a lot better. The challenge is that it's a lot harder to put on, and people have reported having contact issues, like proximal contact issues, because the pressure or the strength of the dam can cause the teeth to move a little bit. Local anesthesia really in dentistry in general, big game changer. I can't imagine a world where, there's stories from the American Civil War taking teeth out without LA, and just the horror of even the thoughts of that. But local anesthesia really has allowed us to take our time and to do things at a much higher level because we can take our time. So, when you're giving local, a lot of patients, their main complaints are, I'm afraid of needles and I'm afraid of the drill. The drill we kind of have to use now. You can give them headphones and all this sort of thing. But LA, I believe, can be a lot more painless than what we are currently doing. And the reason being is, patient will really like you a lot more if you don't cause them pain. And the key to giving LA for me is topical. And we're using like a flavor topical. It's not candy cane, but there's another. I just like the name candy cane. That's why it's on the slide. You just get an earbud, a Q-tip, put put the topical on it, and dry the area you're going to apply LA to, and just rub it in. Rub it in for a good 20-30 seconds. And then what I do is I get topical spray and spray it into the same area, and we just leave that for 3 to 5 minutes. And in the meantime, what I'm doing is I'm setting up my rubber dam, I'm checking pre-op contacts, and just looking at the radiograph or something. Uh, and that will allow you to give a lot more painless injections, and your patients will love you for it. And let's just take a moment to appreciate Hurricane. What a great branding name. The marketing team knew what they were doing. So let's get into some cases. So this is a very, very simple kind of a case, a typical mesiobuccal cusp fractured. Patient comes in, no pain, no sensitivity, and he's just wants to get it fixed. So if we look at this tooth from the radiograph and the exam, we know there's no caries, although we may still find something underneath. Let's make a decision on the cusps. So distal lingual, distal buccal, we're not losing those cusps. Mesiobuccal is already gone. Mesiolingual, let's see, maybe we might. So we begin our restoration removal and caries removal. I have a wedge between the teeth, and the reason for that is it crushes the papilla, it creates a little bit of separation, and it protects the rubber dam from tearing when you're drilling your box. Sometimes a lot deeper. I didn't know how deep it was going to be, and the wedge protects the rubber dam. And we're using caries dye to guide our caries removal, objective caries removal, like I mentioned earlier. And this is the after air abrasion. I'm using a Danville unit, which is a dry system. There's a lot better systems out there like AquaCare, which has water. And, I find with the dry system, whenever I leave the practice, there's like powder coming out of my ears and my hair because it just goes everywhere. But for good adhesion, we know we need to have a really clean surface, clean, free of plaque, free from oils, from drilling, all the other stuff that gets on the tooth when you're doing work. And then the other reason we want a really rough surface. So air abrasion provides a clean and rough surface, and that's ideal for good adhesion. And you can see there, respect to the endpoints, there's still dye over the deep areas, and we're not going near that. So in this case, I used a Paladin system. You can see the ring has seen better days, but a Paladin veering system where well, I think it's a 5 millimeter molar band and the large wedge, the light color blue wedge, and the separating ring. In terms of separating ring, its only purpose is separating the two teeth to get a better contact. But a lot of the times, if I have the matrix and the wedge in, and there's a good seal and a good contact, I don't use the ring. So the ring is a maybe. It's not always used. And in this case, I'm selectively etching the enamel because I'm using a Generation 6 self-etching adhesive system, Clearfill SE Bond 2, which has a self-etching primer and an adhesive to it. And the nice thing is, they say etch dentine for 10, 15 seconds, but by the time you have the etch on, 5 or 10 seconds are gone already. So I let the chemistry do the work. I don't rely on myself to count the seconds. Let the SE Bond primer self-etching do the work. So I built up the mesial and the buccal wall kind of in two increments, buccally and then mesially. Then what I did is seal the dentine with a little thin layer of flowable and using Everex as my dentine replacement. Everex posterior is a fiber reinforced composite. It has really, really good structural properties. And for me, I use it for all the dentine replacement now on posteriors. It comes in a kind of capsule form and flowable, and it can be quite sticky and it's a very hairy looking composite. But the best way to kind of use it is use a microbrush to just pack it in. If you use instruments, I find it just pulls it out. And we did a kind of a cusp by cusp build up of this tooth. And you can see I did a bit of soft flexing around the proximal there to get a better contour. And a little bit of tint in there as well. I think it's ochre tint. And then our occlusal check. So, I don't mind the contact on the restoration, but where I do not want contact is on the margin of the restoration and on the marginal ridge because that's unsupported. And, those two are the kind of the weak areas of our restoration. So as long as we don't have contact there, we can have contact on the restoration. So a bit of a different situation. Back-to-back caries, class twos, adjacent to each other. Again, similar sort of a thing. Caries dye, wedge in, air abrasion, selective etching, and that's the restorations. I used a Tor VM matrix in this case. Probably the one I like the most is the Tor VM because it's a very stiff matrix band and it doesn't distort when you're pushing a wedge in or putting pressure on it and really holds its shape well. And I've used a bit of brown and ochre tints here as well. And back-to-back class twos are actually misleadingly difficult. You may think they look easy, but they're not that easy to do. The way I do these is I put the two matrices in together and put the wedge in and do the distal cavity first. And the reason being is because I finish each restoration before doing the next one. And by doing the distal first, what it allows you to do is use the soft flex on its backhand, which is a lot easier to use and a lot easier to get a good shape with than using it on its front. And then you can do the mesial cavity after. So the two matrices go in together, the wedge goes in, one cavity, the distal cavity gets restored. Then I remove one of the matrix bands, remove the wedge, put the wedge in again. And at this stage, I might use a ring. I might use a ring more for this than a single tooth restoration. And the first restoration is finished entirely before starting the second one. I used to do them kind of together, have the two matrices together, and about 80, 90% of the time you get it right, but the 10, 20% you don't. It's a lot of work to redo the whole thing again. Problems like open contacts, that sort of thing is what I'm talking about. And occlusal check again. Again, a bit of contact on the restoration, but don't mind that unless it's on the margin or on the marginal ridge. So let's get into something a bit more meaty, a bigger sort of a case. This patient had a periodontal treatment, non-surgical treatment, and then osseous resective surgery, and was referred into me by the periodontist, and he was basically saying, "Oh, look, I need you to replace these restorations. They're causing him sensitivity. There's pain on biting on the six, and the contour of the restorations is not great." And he's a periodontal patient. That's the last thing we want is more plaque on the teeth. Give me a second. Okay, so that's the pre-op situation. And let's look at each tooth individually and kind of decide will we be doing a direct or an indirect restoration. Now, if we look at that seven, you can see most likely the cusps are undermined. So indirect. The six, pretty easy one. That's definitely an indirect. The five, probably, I'd say you don't know until you remove the restoration because it's kind of borderline. And the four is a direct restoration, most likely. So we begin our removal process, reducing the cusps, removing the old restoration. There's some caries, removed all that, put on the rubber dam, caries, dye guided caries removal. The four got direct composite. This is I think it's Estelite by Tokiyama. Very nice, very beautiful, translucent composite. I use the Tofamar in this case. The problem with the Tofamar is it gives you a very harsh flare of the tooth, whereas the tooth is more kind of C-shaped in the proximal area. But what you can do is you can just correct that with the Softlex. Tofamar is very easy to use, so I just used it in that case. And the tooth beside it is indirect, so I knew I had room to correct the profile. You can see me sweating here on the distal of the six, mesial of the seven, and trying to clear the enamel. And this is a monolithic Emax pressed, stained and glazed with a Mayo kind of, it's a staining system, ceramic staining system. Beautiful lab work from the technician. And these are bonded in place. And again, we're checking our occlusal contacts. So much more favorable situation. There's no more pain on biting. There's no sensitivity. It's a lot easier to clean these restorations. And that's a before and after. So radiographs. So this is something I only started doing probably in the last year, is taking post-cementation radiographs. And I cemented these restorations with a rubber dam. And even then I have cement there, and I thought I had removed all the cement. Now that's a big problem in a periodontal patient because that cement is going to drive periodontal disease to get worse. So we really need to remove it. So I went in again, it's really difficult in between restorations trying to remove cement. It's hard to often see back there. And that's a radiograph about 6 months later, still a little bit on the mesial of the five, but a lot better. Okay, another sort of a similar case, patient comes in, fractured lingual palatal cusp on the five. I think she's missing four, previous orthodontic treatment. And then mesiobuccal cusp on the six. And the seven just looks like it's going to explode as well. But in this case, we decided just restore the five and the six initially. And, just by looking at those, based on what we said earlier, probably most likely going indirect. So we begin our process again, rubber dam on, Brinkler clamp as an accessory clamp to get retraction of that broken palatal wall. And you can just see cracks galore underneath, under amalgams. You'll often find under amalgam, there's loads of cracks. That doesn't mean they all need endodontic treatment. That's based off the preoperative endodontic diagnosis. So these teeth were vital. There was no pain, no sensitivity. You can see we're getting quite deep on the mesial of the six there. That's the IDS layer sealing the dentine. Now, while she had temporaries on, what happened was the disto-buccal cusp of the seven broke as well. And, partly I believe this is probably my fault because the temporaries were a little bit infraoccluded. So there was now heavier contact on the seven, which probably accelerated its fracture than otherwise. But, she was like, I was like to her, let's just go indirect on that as well because it's not a lot of extra work to do an additional tooth. So in this case, we Again, it's Emax is what this is, monolithic Emax pressed. Prefer pressed over milled because milled you can often find the margins are very chipped or very uneven because the milling machine has a minimum thickness which it needs to mill to, and then the ceramics will adjust that afterwards. Pressed, you can get a lot better margins. And this is our cementation process. So we're using rubber dam. And what I'm doing is I'm etching the ceramic for 60 seconds with 9.5% hydrofluoric acid, then phosphoric acid, and you can see the really nice chalky etched appearance, etch pattern on the intaglio of the ceramics. Then we're combining a drop of primer and silane and mixing it together in a 1-to-1 ratio and applying it to the ceramic. And that's kind of a recommendation from Ray Bertolotti, who's a big adhesion pioneer as well. And then we apply our adhesive system. So either using a resin cement like a dual cure like Panavia or Variolink, or you're doing composite. And my preference is a composite because better properties and better margins, I find. It is a lot more difficult to see the restoration, so you have to really go for it when you're pressing it down. Um, but if a ceramic restoration is very thick, like more than 3 millimeters, I'll probably go for a dual cure resin because cement, because I'm worried about the light cure reaching the composite through the ceramic. And what I'm doing is we're putting the ceramics onto it's just a mug heater, $50 from Amazon. And what it does is it makes the ceramics really, really hot. And that really helps with when you're seating it to spread the cement, because when you're using composite's a really good insulator and it absorbs a lot of the heat. So by pressing it down when it's hot, it just spreads like butter. A lot easier to cement your restorations. That was a big tip that I got off one of the dentists online. And in this case, we're etching the enamel, doing nice, chalky appearance. Always look for that. If it's not chalky, it's not etched. PTFE just isolates the five. I did a crown. I ended up doing a crown on the five because, buckily, because of aesthetics. The patient, I didn't want them to see the transition, and then belatedly, I had no enamel, so because it was fractured, if you remember previously. Yeah, see, there's not a lot of enamel there, so I decided to go for a crown on the five. That's one going on, heated composite in this case. Six going on, cleaning up a little bit, and then five cemented just with the dual cure resin cement. You can see relatively good shade integration in the upper right four there. The five, sorry, and then the six and seven, you can see the margin, but it's the six and seven, so we're okay with that. And that's the final restorations when she came in for review, and occlusal contacts and radiographs. And you saw I cemented them with a rubber dam, and even then there's cement there. Medial of the seven, distal of the six, you can still see cement there. So I'm taking a lot more of these post-operative radiographs, and even when I'm cutting off old crowns, or when I get referred something and there's old dentistry, there's always like a ton of cement or something stuck. A lot more than there should be. So a note on articulation. So here, how do we check our occlusion? Because it's a quadrant of essentially a quadrant of onlays. What I'm doing is I'm checking the static contacts first. So I get the patient to tap, tap, tap in MIP, ICP, whatever you want to call it, tap, 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 and then look at the articulating marks. And ideally what I want is a contact on each tooth, obviously. I don't mind a functional contact, and I don't really want contacts on inclines because they're non-axial forces on the tooth. Really what we're looking for is compression on the teeth. Then what I get the patient do is bite down, and I check with shim stock. Articulating people will mark the teeth, but then you have to confirm the contact and by shim stock. And ideally, we're looking for shim stock hold on the teeth, because posterior teeth are what we want our bite to be supported by. On anterior teeth, I would prefer if the shim stock drags through, except the canine, which is a guiding tooth. So 3, 4, 5, 6, 7, ideally shim stock hold. 2 to 2, ideally shim stock pull. But we still usually want coupling of the teeth. So then after that, we go for red articulating paper and get the patient to grind side to side. What we're trying to see is there any guidance on the teeth. So ideally there shouldn't be any, because we want separation of posterior teeth when we're grinding side to side. But if there is, we're just going to shallow that a little bit so we reduce the non-axial loads on the tooth. In this case, the patient had canine guidance, so there's complete exclusion of the 3 posterior teeth there. Another thing is really dry the teeth prior to using articulating paper, because if it's wet, it may not mark so well. And then use a known thickness of articulating paper. 200 microns is what I use for static contacts because it marks really well, and then 40 microns for dynamic occlusion. So this is the final case, case 5. And this is a combination of composite and ceramic work. You can see mesial caries on the 7 there, and then big onlays, fractured palatal cusp of the 5. And the patient came in complaining of the 5, which was broken and repaired somewhere else, and she just wanted a solution. So I told her there's caries on the 7, so we have to do the 7 and the 4. The 4 I meant. We have to do the 7 and the 4. But the 6, you can see there on the mesiobuccal cusp, there's kind of a lost restoration, and that would benefit from restoration as well. So I made the proposal that, look, we can do the other teeth in this quadrant at the same time if you wish. And, some patients, maybe 30, 40% of patients will say, yeah, why not? Let's do it. So in this case, the plan is to do indirect restorations, 4, 5, 6, and then direct composite on 7. Just getting the shade tab photos before we start. We know teeth can dehydrate significantly during treatment. So if it's aesthetics is an issue, like on the 4, especially on the 5, and sometimes the 6, depending on how wide they smile, we get shade tab photos at the start of treatment. Before LA, it's the first thing you do on the appointment. And I take these photos with different flash settings. So a normal photo, a medium-ish photo, and then a dark photo. And the dark photo really helps the technician with the value. Value is often the most difficult and most noticeable part of matching a tooth. And then make sure at least one of the photos shows the description of the tab. So there's no point having shade tabs and photos if you can't see what letter or number it is. So we begin our removal, removal of old restoration, removal of caries, rubber dam on, and Brinkler clamp again to retract the deep margin on the palatal. Caries dye, guided caries removal. Air abrasion, clean and rough surface prior to sealing the dentine. On the 7, direct composite restoration, and just any sectional matrix band there, and then we're doing sealing our dentine. On the 4, I decided going to do a crown because I want to include the buccal wall, and then the palatal wall doesn't have any enamel. So we're doing a core buildup on that tooth. This is just some air abrasion shots. And this is a monolithic Emax press again. And again, the benefits of press over milled is that you get better margins because the milling machine has a minimum thickness of the burr. Beautiful ceramic work from Final Dental Lab in the UK. You can see nice little white halos on the posteriors as well. The 4 was just a crown, so I used no rubber dam, just gauze and cotton rolls and PTFE cemented with a Variolink. And then I put the rubber dam on for the other 2. So really good isolation for bonding partial coverage restorations or full coverage. Same as before, selectively etching the enamel, Clearfill SE bond primer adhesive. Using heated composite in this case, really pushing down the restorations multiple times to make sure they're seated. And the amazing part of a heated composite is so easy to clean up because it's thick and it comes off really nicely. That's them cemented in place. Occlusal view and rubber dam off to check our occlusion. And that's the final restorations then at the end. So again, checking occlusion like before, static contacts, blue articulating paper, confirming it with shim stock, then dynamic contacts on the red articulating paper, ideally having none on posterior teeth. And that's the end of today. Thanks everyone for listening. I really enjoyed presenting this today. If anyone has any questions, I'm happy to answer. Otherwise, you can connect with me or reach me on Instagram or via email. So thank you very much.